Hello, welcome back. This is our continue. This we are continuing. Angina, we discuss pathophysiology. Now we are going to discuss clinical features. So first of all, it is actually chest pain or discomfort. So will discuss more about this chest pain. There are some characteristics that we define angina. So first of all, there is onset. Onset is it is mostly provoked by exertion or stress or supine position. Okay, supine position because when patient is supine, there is increased blood to the heart from the lower part of the body, and it leads to congestion. Okay, so sometimes patients develop chest pain or discomfort on supine position. Then the type of chest pain, it is constricting, band like, burning, heartburn. It's like tightness. That's how patients usually describe that pain. Location is it will be mostly diffuse. Sometimes it is also described as retrosternal. Okay, now always the chest pain, especially the pain because of the heart, it will radiate. Okay, so it will radiate to bilateral arms most commonly. Okay, so you must have seen patients complaining about left arm radiation of the chest pain to the left arm. So it is very common. It can radiate up to lower jaw, and it can also radiate to epigastric region. So sometimes it mimics like acute gastritis, and that's why ECG is always needed to differentiate between gastritis and cardiac pain. Okay, then progression. So any complaint you will describe this way. Okay, onset, duration, progress, type of the pain, location. Okay, so progression, it is gradually progressive. Okay, relieving factor is angina is especially stable angina is very classical. It gets relieved by rest or nitrates. That means removal of provoking factors. Okay, so if exertion causes chest pain, removal of exertion, that means on rest it disappears. Okay, so it usually lasts 3 to 5 minutes. It is very commonly, very characteristically it lasts 3 to 5 minutes. It is never more than 20 to 30 minutes. If it lasts more than 20 to 30 minutes, it is described as ACS, that is acute coronary syndrome. Okay, and one sign I wanted to discuss is Levine sign. Levine sign is patient describing chest pain with the wrist. Okay, wrist in the middle of the chest. Okay, over the sternum. So this is called as Levine sign. Okay, now angina is associated with few symptoms. They are also known as angina equivalents. Okay, in patients like diabetics or in elderly patients, sometimes they don't have chest pain. Okay, so they present with only angina equivalents. So what are this angina equivalent or associated symptoms? It is dyspnea. It is very commonly present with dyspnea, increased sweating, which is also known as diaphoresis, belching, nausea. So I told you it will mimic like acute gastritis. So we need to differentiate between acute gastritis and angina. It also presents with dizziness, fatigability, weakness, very commonly presents like that. Okay, it is this angina equivalent is more common in women than men, and obviously I told you diabetic and elderly will usually present with only angina equivalents and not chest pain. So for diagnosis you need ECG, obviously cardiac biomarkers most commonly uses troponin T and I, stress testing, CT angiography that will give us an idea. It is a non-invasive angiography. It will give us idea about the patency of coronary arteries. And last is if everything is normal and still patient is complaining of chest pain, then we will plan coronary angiography. Okay. Now, first of all, management first line is lifestyle modification. Okay, so these factors that are responsible for myocardial ischemia or atherosclerosis, those risk factors we have to decrease by lifestyle modification. They are first of all smoking and alcohol. Okay, it is very commonly associated with atherosclerosis, and it accelerates atherosclerosis. Okay, so you have to stop smoking and or stop alcohol consumption. Then obviously hypertension, diabetes and dyslipidemia are very important factors for myocardial ischemia. Then weight loss or graded aerobics plus strength exercise. So what happens is when patients are doing aerobic exercise, they have increased O2 demand and they develop collateral blood supply. So it has to be graded because already if patient is having angina, then it has to be graded. Okay, and then comes pharmacological treatment. First is low dose aspirin or clopidogrel, most beneficial in angina. Then statins, obviously, to decrease the cholesterol. Then beta blockers and CCBs. For angina specifically, These are first line, okay, first line treatment, first line drugs. Okay, you can start either beta blocker or CCBs, and then you reach up to maximum dose of either of them. If still symptoms persist, then you can combine also. But when you combine beta blockers with CCBs, you cannot combine with verapamil or dilzem. You or that is non dihydropyridine CCBs. You have to combine it with dihydropyridine CCBs like nifedipine. Okay, so if you're combining, it has to be because non-DHP CCBs and beta blockers together will lead to severe heart blocks and bradycardias. So you have to be careful about them. That nitrates. Okay, so as I told you, nitrate is a relieving factor. So we give immediate. Actually, we prescribe patients SOS. Like whenever patient develops this kind of chest pain during exertion, we tell them to take sublingually, short acting, immediate acting nitrates. Okay, and then if on CCBs and beta blocker, if patients develop complaint, then we prescribe long acting nitrates like isosorbide mononitrate. Okay, then obviously other drugs are ivabradine, which is ivabradine, ranolazine, and nicorandil. Okay, these are even after beta blocker, CCBs, and nitrates, patients still have symptoms. We prescribe these drugs. But I want to make a point here. If on CCBs and beta blockers, if patient is developing complaint, then you have to plan further management, like any invasive management, like coronary artery angiography, and see if anything like stenting is needed. So ivabradine, ranolazine, and nicorandil are only symptomatic, not very much helpful. Okay, and ACE inhibitor or ARB. So remember, beta blocker, ACE inhibitor, ARBs. These are the drugs which are actually showing mortality benefit in heart diseases. Okay, especially ischemic heart diseases. Okay, so if patient is having along with angina or along with ischemic heart disease, there is hypertension, then you have to consider ACE inhibitor or ARB also. Okay, or if there is proteinuria, or if there is any known cardiovascular disease, previously known proven ischemic heart disease, then you have to consider ACE inhibitor or ARBs. Okay, thank you so much. If you like my video, please like, share, and subscribe. Thank you.